This PowerPoint presentation will describe fieldwork procedures for the DESCANT study and is split into 5 sections. By identified carer, we mean the primary person who feels responsible for and supports the person with dementia. The study inclusion criteria do not include people who attend a memory clinic and do not receive a diagnosis of dementia. The clinic ID, 2 digits, will be provided by the trial manager at PSSRU. All patient numbers, final 3 digits, should be allocated by the site coordinator locally to avoid any risk of duplication. It is essential to ensure the correct 5-digit ID code is entered onto the questionnaire and the consent forms. Patients who subsequently refuse or drop out for any reason will keep their ID number. Each interviewer should be allocated their own individual ID number. This will be a 4-digit number containing the clinic ID of 2 digits, followed by the interviewer's 2-digit number. The interviewer ID number will be allocated by the site coordinator. This will identify who has completed the questionnaire and ensure the appropriate interviewer is contacted to complete the follow-up interview. NHS R&D offices can offer advice and support to the local research team. Your NHS manager has responsibility for ensuring that you are fully conversant with any safety regulations and for implementing any local lone worker systems. Interviews can be ended at any point if either the patient or the carer wishes. Alternatively, you may choose to take a short break. The following slides contain additional directions or information for administering the measures used for this study. For B6, code only one option. If the patient is temporarily living elsewhere, do not code the temporary accommodation but their permanent address. If the patient doesn't live with the carer but in their own home with a spouse or partner, then code the first option, living in own home with spouse or partner. If living with another relative, such as a sibling, son or daughter, who is not the carer, code as other. B7 relates to the tenancy of the house, so if the patient lives with someone else, it is the main occupant's tenancy which is recorded. For B8, record whether the patient has stayed elsewhere for any short period of time, including overnight. If they are unsure whether a home is residential or nursing, please note as uncertain against the most likely option. Other relative includes siblings, grandchildren, nephews, nieces, cousins and so on, regardless of level of contact, and also include in-laws such as brother or sister-in-law, son or daughter-in-law. Note that in question 2, if you have any children, where does your nearest child live? If the nearest relative is also their child, question 2 will be the same answer as question 1. Please refer to your manual for the full instructions. Question 4 is a test of attention rather than a test of spelling, so it is important that you spell out the word world and do this for all respondents. Then ask them to spell world backwards. They get a score of 1 point for each correct letter recalled in the correct place. Allow some retrying provided they succeed fairly quickly. Write what the respondent says below the question to aid scoring. For question 12, when handing the paper to the respondent, hold it in front of you. If they can only use one arm, change the instructions to account for this. Provided the respondent carries out the command according to what you have asked, they can receive a score. If they have a physical impairment which makes it painful or difficult to reach the floor, you can substitute "put it on your lap" rather than on the floor. Again, provided they place the paper in their lap, they can score a point for this. Read each question exactly as it is written. If the patient does not understand a question, reread but do not rephrase. If the person doesn't understand the general quality of life final question, repeat the entire sentence and question, and if still not understood, ask, "Thinking about your life in the last week, would you say it was very good, good, fair, or poor?" These questions are a central part of this study and should be completed as accurately as possible. The first 2 columns are to indicate whether or not the patient has received any help from the specified workers or services. The next 2 columns are to record the number and average duration of visits in the last 3 months. A monthly call will be 3 visits. If visits are weekly, 3 months is 13 weeks. Thus a weekly call over 3 months is 13 visits. If a respondent is unsure about the frequency of receipt of a service, probe for a reasonable estimate. For example, the respondent may know that they have seen a GP in the last 3 months, but can't remember how many times. Tick the received column and ask for an estimate and write in, for example, 3 or 4 visits. If the respondent is unable to estimate, write in "not known." For daycare, the number of visits equate to the number of days attended. A full day's attendance would normally be around 6 hours, or 360 minutes. If an individual attends daycare, check whether they use transportation and code separately in the box above. For short-term respite care, the number of visits equates to the number of days respite. For each day of respite, the duration of visit will be 24 hours. S2, A and B. Inpatient and outpatient services. This contains only 2 response columns. Note that column 1 is for recording the number of admissions for inpatient or number of visits for outpatient and are not tick boxes. Column 2 is to record the number of days or number of hours of received care. Inpatient services. If a respondent has been transferred onto different wards during their stay, record all of these and the number of days spent on each type of ward, even if this was just one stay. For example, 2 days on ICU, 3 days on coronary care and 3 days on general medical ward during one visit. Intermediate care will be coded as other inpatient visit, whether provided in hospital or nursing home. The type of inpatient ward should be coded according to the ward that the person was admitted to, rather than their diagnosis. For example, If they were admitted for a medical complaint, but they were given a bed on a surgical ward, this would be coded surgical. For any inpatient service not specified, provide as much detail as possible about the type of ward, such as ICU, coronary care, orthopaedic, elderly care or geriatric care, and so on. Accident and emergency, treatment in A&E should be coded as outpatient unless the person was admitted to a ward overnight, which would then be an inpatient visit. For outpatient services, code memory clinic or memory service visits as other outpatient visits. Code under psychiatric outpatient only if the participant saw a consultant psychiatrist. In this study, questions about aids and adaptations for patient and carer are recorded separately. Record all types of adaptations used, and in the right-hand column note who was paid for this: the patient, carer, local authority, etc. Please record if not known. For each category, please tick one box on each line to indicate the patient's level of impairment in that area. Please record impairment only due to cognitive loss, not impairment due to other factors such as physical handicap or depression. Use all information available and make the best judgment. Occasionally the evidence is ambiguous, and the best judgment is that a category could be rated in either one of two adjacent boxes, such as mild 1 or moderate 2 impairment. In that situation, the standard procedure is to tick the box of greater impairment. The Fieldwork Manual describes two ways of obtaining the overall score. Please use the approach that you are most comfortable with. For the research, how the score is completed is unimportant. What is important is that there is an overall score. As noted previously, there is the option for the carer to complete this interview in private if they wish. It's important to be as accurate as possible in completing this question. Sometimes carers find it difficult to estimate the number of hours spent on activities of daily living, instrumental activities of daily living, and supervision. If necessary, break down ADLs and IADLs into specified activities and ask if their relative needs assistance with each. And if so, how long would they spend on each? And then add up the time spent. If a carer responds all the time, or 24 hours for supervision, establish how many hours sleep the carer gets, subtract this from 24 and confirm this with the carer as the daily number of hours of supervision. It is important to ask at B7C whether the carer is paid to care for their relative in case they assume this is not included here. Please check that paid care is in respect of the patient. B8 should be completed as usual hours if the person is temporarily off sick and still receiving pay from their employer or intending to return to work. Make a brief note of the circumstances on the questionnaire. H2 measures the presence of psychological distress and minor psychiatric morbidity. H5 measures the carer's own competence to cope with the demands of caring for a person with dementia. If the carer feels that a question does not apply to them for any reason, code the answer as disagree very strongly, i.e. they do not experience burden in relation to this question. This measure assesses the quality of life of the patient from the point of view of the carer. If the DEMQual was not completed in questionnaire A with the patient, this proxy version with the carer should always be completed. If question H1 in questionnaire A is completed by the patient, skip question H7 here and go straight to question H8. In question H8, the carer is asked to tick the box that most closely describes the level of ability of their relative. Not applicable should be selected only if the patient did not do that activity when they were well. The instructions for completing this are the same as for the patient. As noted previously, in this study questions about aids and adaptations for patient and carer are recorded separately. Record all types of adaptations used, and in the right-hand column note who has paid for this: the patient, carer, local authority, and so on. Please record if it's not known. Follow-up interviews should be completed ideally between week 12 and week 14 following the baseline interview. In some circumstances, for example due to participant illness or holidays, interviews could be completed until week 16. It is the responsibility of the interviewer to inform their local site coordinator if they are having difficulty for any reason recontacting the participant or completing the follow-up. If the follow-up interview is still not arranged at 16 weeks, please contact the trial manager at PSSRU. In selecting sites, some follow-up interviews will be audio recorded to capture values and experiences expressed during the process of data collection. In these selected sites, the trial manager will inform your site coordinator if a particular follow-up interview is to be audio recorded. Initially, follow-up interviews will be conducted at 52 weeks. As the study progresses, this will reduce to 26 weeks. The trial manager will inform you when a follow-up interview is due. It is the responsibility of the interviewer to inform their local site coordinator if they are having difficulty for any reason recontacting the participant or completing the follow-up. If the follow-up interview is still not arranged at 30 or 56 weeks, please contact the trial manager at PSSRU. Please email the training declaration form to descant@manchester.ac.uk.